Thank you very much for that round of introduction, Brian. Thank you, my dear friends, for joining this webinar. Thank you, ISQua, for giving me this wonderful opportunity. I bring greetings from the Christian Medical College, Vellore, also the Consortium of Accredited Healthcare Organizations of India, and from India. I'm going to present to you today the operational preparedness of hospitals in India towards this pandemic that we are facing. For those of you who do not know my country, India is one of the oldest civilizations with very rich cultural heritage. We have the Himalayas in the north, Bay of Bengal in the east, Arabian Sea in the west, Indian Ocean to the south. We are a huge country, 7th largest country in the world, with an area of about 3.3 million square kilometers. We lie entirely in the northern hemisphere, land frontier of about 15,200 kilometers, and a coastline of about 7,516 kilometers. And we border 7 countries and a small country in the south, which is Sri Lanka. The government of India, it is one of the largest democracies in the world, with over 900 million eligible voters as of 2019. It's a federal form of government called the central government, with elected officials at the union, state, and the local levels. We have 28 states and 8 union territories. To put it in perspective to you, 28 states are like 28 small nations. And each of these union territory, again, is like a small nation. So India, it's a subcontinent, it's a huge country, and it's very, very diverse. About the health indices of India, we have a population of about 1.3 billion. Total hospital beds in India is about 19 lakhs. And we have a very unique system of public sector and private sector. We have huge number of private hospitals, and the beds, they cater to about 12 lakh beds. Public sector is about 7 lakhs. Total ICU beds in the country is about 95,000. Ventilators about 48,000. And life expectancy, male it's about 67 and female it's about 70. The number of doctors in this country to a population of about 1,000 it's about 1 for every 1,456 and 1.7 nurses for about 1,000 people in this country. So this is about my country. And when this pandemic started, the first case of COVID-19 came to India on the 30th of January 2020. And to be very precise, and I think our government has done a wonderful job. They have looked at it very carefully, the things that are happening across the globe. And they brought out what is known as a voluntary public curfew on March 22nd, which almost was like a prelude to the curfews that were coming in the coming days. And when the number of confirmed cases reached about 500, we had our first phase of lockdown, March 25th to 14. It lasted for about 3 weeks. And thereafter, the second phase between April 15th and 3rd, third phase between May 4th and 17th May. And now it is relaxed, but we are still under lockdown. Phase 4, we are in the phase 4 lockdown, May 18th to 31st May. Of course, there are a lot of relaxations now, and we have 3 zones, red, orange, and green, each with certain relaxations. Putting that together, the pandemic management in India, as I told you, we have 28 states and 8 union territories. Health is a state subject. Health is not a central subject. So therefore, individual states actually operationalize health. They are responsible for public health in the states. However, pandemic allows the center to take charge. And that's exactly what has happened. Center used the provisions of Disaster Management Act of 2005 and Epidemic Diseases Act of 1897 to take control of the public health. Center listed down the restrictions. States are allowed to enhance restrictions but not relax without consent from the center. I think that has worked out extremely well. Those states complain that the control is in the center, but they're allowed to enhance but not reduce. Therefore, you still have control over what different states were doing. Management by the Indian states. There have been excellent pockets of excellence that we have seen. There are various models. As I mentioned before, we have both the public health and the private health. Public health is funded by the state and private health is out-of-pocket expenses. And we have a huge number of private healthcare facilities in this country. Different states have handled this pandemic in different ways. Now, I'm going to put across two models to you. One is the Kerala model and the other one is the Odisha model. Kerala is a state in the southernmost tip of India, and the literacy level in this state is quite high. Kerala handled this pandemic in a very beautiful manner and almost they flattened the curve. But their model is completely a public health geared model. Patients were not admitted in the private healthcare facilities. Their public health system is very strong. They manage Nipah extremely well, which otherwise would have probably ended up as a pandemic. Their experiences from Nipah taught them, they strengthened their public health system based on that, and it has given them valuable lessons. They went into contact tracing in a big way, isolation, and completely managed by the public health facilities. Now coming to the Odisha model, Odisha is a state, the northern part of India. Their model is a public-private partnership. They engaged with the private hospitals. They identified private hospitals. They combined their efficiency of public health and the private health, increased testing, effective resource allocation, swift partnership with the private health sector, infrastructural setup, capacity building of human resources in healthcare, and even incentives for citizens to test. So that model has also worked out effectively. So each state, I live in a state called Tamil Nadu. Here again, private hospitals manage COVID patients, but selected private hospitals. And state decided that these are the hospitals that are going to manage the pandemic. So different models in different states. And that's how we are managing the pandemic in India. I really appreciate these words put across by Vineet Chopra, the Chief of Hospital Medicine at University of Michigan's Academic Medical Center. And he says, it's time to set aside the business as usual mindset. Even if large number of severe cases don't start appearing for weeks, every moment spent on preparations now will pay off. So we started way ahead of time with the preparedness. I think these golden words are the ones that we took. The moment China started, the pandemic started, we started with the preparations here. Now, what is this hospital preparedness? Every hospital in collaboration, which is what is extremely important, with other hospitals and public health agencies will be able to provide appropriate care to COVID-19 patients requiring hospitalization while maintaining other medical services in the community, both during and after the pandemic. This definition recognizes what constitutes appropriate care, and the criteria for hospital administration may well change during a pandemic. So it's all about preparedness and how prepared you are before the pandemic began. Now there are 5 phases. One, the first and the foremost one is prevention and preparedness phase. No infectious diseases emergency. We tend to have a plan in place. You conduct some annual mock drill. And that's the phase which is the prevention and the preparedness phase. Then comes the second phase, which is a standby phase, where there is a global outbreak and it has the potential to reach your country. And you then look at advisory, what is coming from the government and the proposed action plan. The third phase is the initial action phase. The pandemic declared by WHO, your HICS starts getting activated in your hospitals. You start triaging, you start cohorting, and your IPC measures get strengthened. In our country, we are now in the targeted action phase, which is stage 4. Pandemic declared by WHO. We have widespread number of patients who have COVID-19. HICS has been activated in all hospitals. Communicate, empower, engage with the stakeholders, including the community. Strengthen and implement surge management strategy. That is where we are in. And we are hoping to reach the stand down phase very soon. we are hoping. Now, this accreditation has taught us wonderful lessons, at least for majority of hospitals in this country. Now, this almost used to be in paper. A decade back, we never had the concept of emergency preparedness in our hospitals. With regards to fire disaster, the Amri Hospital disaster, where we lost about 92 lives, taught us valuable lessons to be prepared for any fire emergency. There is a clause in NABH, which is a standard, which is COP4, which talks about the organization preparing itself towards managing patients during community emergencies, epidemics, and other disasters. So at least those hospitals that were going in for accreditation used to prepare a plan, a documented plan, have some kind of mock drill happening, activate the hospital information command center, and some baseline work was happening. Now that has proved to be extremely useful for us today when we are actually facing a pandemic situation. We started following guidelines, particularly the CDC guidelines, the ICMR guidelines, and the WHO guidelines. We luckily did not have the pandemic, the number of cases increasing in the very beginning. Lessons from Italy, US, and other countries has taught us valuable lessons. So we were able to take best practices from these countries, look into literature, and we have started preparing our own hospitals, looking at evidence-based practices from these guidelines issued by various states, central, and world bodies. Now, I must tell you, this is one situation where hospitals have really got their top management involved. As is given in CDC guidelines or the WHO pandemic preparedness, leading from the front is what is the key. So most of the hospitals in this country, I'm talking from various hospitals in this country because I represent an organization called the Consortium of Accredited Healthcare Organization. We get inputs from all the hospitals in India about best practices and the systems that they have adopted. Most of the hospitals in this country have established the HICS, which is the Hospital Incident Command System. The head of the hospital has taken the overall responsibility. This is a multidisciplinary committee with clinical experts, people from infectious diseases, infection control, pulmonologists, intensivists, operations representatives, inpatient, outpatients, clinical services, nursing administration, general administration, the logistics and the supply chain management in a big way, finance, which is a huge crunch for us here, infection control officers, quality managers, risk managers, all of them involved and leading this from the front. Now, these are some of the committees that most of the hospitals have put together. Committees may be 14, 15 in number, the subcommittees. These subcommittees meet very regularly and present to the HICS. Some have only 4 or 5 committees, but however, all these issues are being addressed by the committees. Patient flow, administrative controls, infection control practices, manpower, training and development, logistics and supply chain management, the clinical management, and the financial management. I will take you across to some of the best practices in each of these areas as part of the preparedness towards the pandemic. Now, coming to patient flow, we realize that this is the most important thing to address. The triage system has been established in most of the hospitals. Patients come in, the triaging happens at the flu clinic, and most of the flu clinics are located at the entrance of the hospital. The non-COVID patients move into the non-COVID areas of the hospital. The COVID suspected patients go for testing, and if they are proven to be positive, they get admitted in either the isolation areas of the hospital, or if they are very sick, they get to the ICU. So this system, I'm going to take you through some of the implementations in hospitals. Different strategies adopted for triage and patient flow. Mandatory for all patients and visitors to wear masks. We started it way ahead of time. Flu clinic at the entrance of the hospital, and all the patients walking through the hospital are screened, and interviews are conducted with checklists. Full protection for the ED staff and the flu clinic staff with regards to the ones who are in the front line. COVID wards, we have created them in separate isolated buildings. For those hospitals that are not able to actually create COVID wards, they are not really admitting COVID patients. Patient cohorting, where are you going to keep your suspects? Where are you going to keep your positive patients? The testing, the patients who are going in for testing, those kind of cohorting has been clearly worked out. Separate route and lift for patients, for staff, for material movement, everything isolated, marked, and the flow marked and taught to all the staff in the hospital. Of course, the staff movement. Now, these are some of the pictures of flu clinic at the entrance of hospitals in our country. Patients screened with thermal scanners, full protection and PPE in ED and flu clinics, COVID wards in isolated buildings, patient cohorting, positive for COVID-19 level 1, 2, 3 with mild symptoms, requiring medical attention, sick and ventilated patients, cohort 2, clinically suggestive but pending test results in single rooms so that you don't put the other patients at risk. And of course, the third cohort, which is your medical emergencies and other patients who are testing negative for COVID. Now, this is one area where we have really focused on most of the hospitals because this is a priority for us to protect our staff, whether it is the doctors, nurses, or housekeeping, everybody needs to be protected. So we have put in very good systems for movement of staff into the COVID areas. Particularly, this discipline has been insisted upon in most of the hospitals. Staff enter the floor in their streetwear and collect scrub suit from the issue counters. They move into the change room, change to scrubs, keep the streetwear and valuables in lockers, which are almost like transit lockers. Go to the donning room of the wards, don appropriately. On completion of the shift, they move to the doffing room, to the respective wards, doff themselves and leave to the donning room where the lockers are kept. Pick up the streetwear from lockers, take shower and move out. And this has been insisted upon in most of the hospitals in this country. And luckily, the number of cases for us with staff contracting COVID-19 has been lesser. There are many administrative controls that have been brought into practice. Only essential services within the hospital are required to function. Creating additional bed support services like transport, particularly in a situation like lockdown, we need the transport facility available to commute between house and the hospital. Entry restrictions strictly implemented. Visitor management during this pandemic period. Donning and doffing supervision. Food and refreshment. Social distancing. Teleconsult and telemedicine. Now, when it comes to entry restrictions, we've been very, very strict on it. Visitor management. Very strict on visitor management. Only one visitor per patient. Now, in the COVID wards, no visitors allowed at all, even if they are suspects. Donning and doffing supervision, which is something we have learned from other countries. Each ward to have one room for donning and one for doffing, very strict. Donning room, appropriate PPE kept ready for the staff. Doffing rooms with bins and other accessories for storage of PPE. And if you are reusing the N95, separate provisions for storing these N95 masks. Now, the other thing which we have brought in is almost like a supervisor on the floor who double checks and ensures that the staff have donned appropriately before they enter the COVID area. And this has worked out extremely well for most hospitals, that we don't want any slips happening when the staff are entering the donning area. And even supervision of doffing has been strengthened. Now, coming to food and refreshments, most of these COVID patients require food to be supplied. They may be just suspects, but you need to provide them with the food that is required for them because the relatives cannot be coming into that area. So you need to run this service 24/7. And in this lockdown period, it's very difficult to get the essential supplies available, including the healthcare workers who are working in these areas. So that is something which hospitals have strictly made possible with the help of the government. Social distancing practiced in every area, whether it is the reception counters or it is the lift. Social distancing and mask mandatory into all these areas have been strictly implemented. Now, this has come as a boom. The telemedicine guidelines of India, and thanks to CAHO, we actually had a public interest litigation for releasing the telemedicine guidelines of India. And that came 5 days after the first lockdown. And therefore, you now see increasing number of patients prefer to consult doctors with some medical emergencies, and they don't need to come into the hospital. So telemedicine and teleconsult has almost become the norm. Remote teleconsultation used very effectively for triaging even potential cases, asking them to come in case they are sick. So this has been a major boon in times that we are not able to actually cater to the patients who would otherwise come to us. Coming to infection control and engineering controls, protocols for anything and everything. Cleaning of all areas, instruments, equipment, linen, spraying, disinfecting. Now, the very, very difficult thing that we have been grappling with are the negative pressure areas. Now, in any hospital, typically in India, you have one isolation room or maybe maximum 2 or 3. We have really never thought through this concept of isolation. Now, in such a situation, we don't have negative pressure rooms. Now, the conversion of the existing rooms into negative pressure areas, also the OTs. Now, we've been very strict with the positive pressure OTs so that we don't compromise on the patients who are getting operated. Now, the concept is towards negative pressure OTs. It has been a very major challenge for the hospitals and, of course, the waste management as well. Now, all the hospitals have identified the high-touch area like telephones, pagers, doorknobs, lifts, elevators, and have put very specific protocols for cleaning these areas and the frequency of cleaning. We have taken wonderful points from the national guidelines brought out by the Ministry of Health and Family Welfare, very specific to our country, with just 1% sodium hypochlorite, because we don't even get chemicals now, the disinfectants now for cleaning. So this 1% hypochlorite works out very well, and the PPE to use under various situations. So we have put in protocols for sweeping, mopping, wall cleaning, toilet cleaning, entrances of all areas, patient awaiting areas. Now, most of the hospitals have actually, they are overdoing cleaning, I would say, because even more than what the ministry has recommended, we're all into a paranoia, I would say, that we are cleaning and cleaning and cleaning our facility almost like every hour or every 2 hours this is happening. Lifts, wiping of wheelchairs, trolleys, phones. So the workload that our housekeeping staff have taken on is tremendously high at the moment. And canteen food services, we've all gone into takeaways, wiping counters and tables very, very frequently, and social distancing practiced in the canteens in the hospital, and of course avoiding common drinking glass and cups. We are encouraging people to take cups into the area. So all these were planned way ahead of time. Therefore, it didn't come as a surprise for our staff. So when the pandemic was declared, all these protocols committees started meeting and putting in protocols in place towards this. Now that we are facing it, it's very easily implemented in our hospitals. Vehicles, ambulance cleaning, what is the chemical to use, what is the frequency of cleaning, who cleans it, what is the PPE to use, what about ambu bag and suction that you are using in the ambulance. All these have been very strictly put down, and the ministry has brought out wonderful guidelines towards cleaning and disinfection of our healthcare facilities. These are some of the pictures of cleaning that happens in our ambulances, in our buses. May not look as fancy as a Western country. However, we are really, really focusing on it and doing it well now, I would say. Spraying and disinfection. I do not know how effective this spraying is, but in my opinion, at least it is giving a feeling that somebody is actively looking into it and spraying, and at least a kind of a decontamination that is happening is the sense that our patients and visitors derive by seeing the hospital facilities sprayed with these chemicals. Now, there's a lot of spraying that happens typically in a hospital in India, but our government guidelines also say so. So we have a lot of spraying and disinfection that happens in our campuses. Hand wash stations. This is something that we have brought into any building entrance. Hand wash facilities are provided. All doctors, nurses, staff entering, wash their hands and get in. And all patients, relatives, everybody, they are expected to wash their hands and then go into the facility. This has been a major challenge with regards to HVAC modification, isolating rooms from central air conditioning, and providing exhaust airflow so that the room is in slightly higher negative pressure condition compared to the adjacent corridor. Positive pressure theatre converted to negative pressure. We are now stressing to our surgeons and our anesthetists on work practice changes. Now we are so used to having 8 and 9 people in the theatre, including the trainees within the theatre environment. So we are trying to minimize exposure. It's not easy trying to explain to them and say that this entire pandemic requires work practice change. So in order to cater to their needs, we are slowly trying to see if we can convert 2 or 3 theatres into negative pressure theatres, at least for those areas where COVID positive patients are admitted and operated upon. And I think most of the hospitals have identified 1 or 2 theatres that could be converted, and they have almost completed. Like my hospital, we have about 2 theatres converted as negative pressure theatres for COVID positive patients. Waste management has been a major challenge. But interestingly, the Pollution Control Board of India brought out guidelines as soon as the pandemic was announced. So how to manage the waste from the quarantine area, from isolation wards, from medical wards, from your ICUs, all that has been clearly put down. The weight is measured on a daily basis and sent to the temporary storage area, and from there it's picked up by the third party. Again, coming to the sewage treatment, which is the waste that is going out from the toilets of these COVID positive areas. Though we are expected to have a zero waste facility to recycle the waste, now the pollution control has brought out a norm that once you treat the waste, then it can be sent into the common sewer, municipal sewer. So every day there are changes in protocols. That is the reason why these committees meet very frequently on a day-to-day basis. Look at the protocols that are being issued, the guidelines that are being issued by the ministry. Make sure that the HICS is aware of it and ensure that the entire hospital staff are aware of the protocols that are put in front of them. Now, manpower. This has been a major challenge for us, manpower, including staff health. But I think we have faced it quite well. Most of the hospitals, we have prepared contingency capacity strategies and also crisis capacity strategies. We have looked at how other countries have managed, and also the ministry brought out some guidelines as to which are the specialities that should be in the front and which are the specialities that should be coming in case of a crisis capacity to add on to to take away the load of the other doctors and nurses who are in the front. So I'll touch upon manpower planning, staff safety, our social and psychological support and skill development. Now the concept that is used is the first line of defense. It's the junior doctors, residents, the DNB residents. Second line is the senior SRs, associates, as attending consultants. And the third line is the senior consultants. And formulating a separate COVID team, which is basically the pulmonologist, the anesthetist, the nurse, the medicine group, ID group, all of them are part of this COVID team. During crisis, planning for other specialty clinicians to be inducted. So though we now know the matrix, we have not reached the stage of a crisis, we clearly know who are the ones who are going to go in when it's 20% capacity, 40%, 60%, 80% and 100%. So therefore the training of all these, the other specialty clinicians, nurses are all underway. And separate roster for COVID area and non-COVID area. Shift rescheduling, because we are used to 8 and 12 hours of shift. Now rescheduling the shift, because the PPE use has been a major challenge. So you have to make sure that you have adequate PPE available. You cannot waste the personal protective equipment. So now whether to go for a 2 shift, 3 shift, 4 shift per day, for the doctors, nurses, all that is being worked around the availability of people and also the availability of resource, particularly without wasting the personal protective equipment. Many hospitals have gone on to, they are almost contemplating between 12-hour and 6-hour shift. But most hospitals have adopted 6-hour shifts so that the doctor, nurse, they come in, complete the shift, doff and move out without any break in the middle. Now, if they want to take a bio break, it is a matter of removing their PPE, all that. So I understand from some hospitals that they're even using diapers for the doctors and nurses. But I think the situation demands so, because the personal protective equipment is a very valuable resource at the moment. Now, coming to training and development, we started investing in training and development as soon as the pandemic was announced by WHO. So what kind of training matrix, who should be trained, on what they should be trained, doctors, nurses, paramedics, housekeeping, technical staff, administrative staff, the entire training matrix the training team took the responsibility to prepare the matrix. What to train, the PPE, donning, doffing for all stuff, because you're not used to this kind of a situation. When you're talking about donning, what is the first step, second, third, and fourth, and doffing, because you compromise on one step, you are going to be in trouble. So therefore, we had to really invest in training, screening tools to be used for paramedics, intubations by non-anesthetists, non-clinical group. How do you go about doing it? Specialty-specific protocols. Now we are moving a patient into the CT room. How do you manage a COVID patient in a CT area? How do you manage him in an ED? All those training aspects had to be developed, vetted by the top committee, and then training to be initiated. And when do you really want to scale up? What is the current situation? Where are you with regards to training? On a day-to-day basis, this has been briefed to the HICS by the respective teams. So I think most of the hospitals, all of us almost, have really invested in training and development. This has been the major challenge, which is the logistics management, which is supply chain management. Whether it is the PPE, medical equipment, disinfectants, and medications. We need the right quality, the right quantity at the right time, justified use, the appropriate use, inventory and adequate stock to be maintained, particularly in a situation where you have a lockdown in the country and lockdown globally. So this guideline was issued by the ministry way ahead of time. But I think this if we actually start following this guideline, you need to provide N95 masks to all workers in the hospital, which is just not possible. So we started customizing to the resource available and who are those frontline workers who require N95, who require the coveralls, the hazmat suits, all those. We started developing the matrix for our own hospitals based on the exposure of these frontline workers. Appropriate PPE use. We started the concept of issuing kits instead of loose PPE because you tend to lose them. And PPE selection through expert committee. Again, a committee set up to select the kind of PPE that needs to be ordered. Samples selected, tried out, fit test before ordering. And once ordering PPE based on current level of consumption as well as assumptions in times of surge. Now, what used to cost us 1 rupee, a medical mask, is today about 12 to 13 rupees. So the financial burden on the personal protective equipment has been extremely huge. So therefore, optimizing the resources, making sure that it's available in a crisis situation has been a major challenge for all our hospitals. Now, almost most of us have the PPE calculator either designed by our own teams or we adopted to the CDC design calculator for 10%, 20%, 30% load. PPE reuse. Most of the hospitals reuse at least the N95 respirators. We have gone into reuse, decontamination of N95, multiple time use. And the PPE quality control, ensured every time the consignment is received. Now, with the need for PPE, we started getting a lot of PPE without certification, appropriate certification. So those were not meeting the standards at all. So therefore, we needed to be extremely cautious in making sure that these personal protective equipment meets the standards prescribed. And it's been extremely challenging doing that. And need for decontamination and reuse. This has been a science by itself. People have all become innovators and inventors. Because of the global shortage of N95 respirators, supply is limited to few sources and the cost escalation as I discussed earlier. Options have been widely looked into. MSGs, WMH, BPHP, and the UVGI. Many hospitals have adopted these for decontamination of the N95 mask. Most of the hospitals adopted to the AIMS protocol of issuing 5 N95 masks to the staff and using it day 1, second mask day 2, third mask day 3, 4, and 5. And then you use it for almost 20 days. So 5 masks for almost 20 days so that you give adequate time for the mask to dry, sun dry them, and you take the responsibility to use these masks. So that has worked out very well for most of the hospitals. Different hospitals have evolved different models. Some of them give 3 masks for 9 days or 3 masks for 15 days. It depends on the area of usage. And measures to conserve the PPE, shifts without break, sample kiosks like the one you see in the picture, where while you are having the patients for testing, you're not wasting the PPE there. You have multiple patients coming, you clean the glove, they disinfect the glove between patients. So this has also worked out very well for us, and extended use and reuse of masks, decontamination of the mask. Medications. Now this is something we worked on way ahead of time. List of essential medicines specific to COVID treatment, and also managing other patients, because in a lockdown you wouldn't get them. Pharmacy to ensure adequate stock available as buffer. Medication return policy. I mean, in a resource limited setup like India, you generally take back the medicines the patients did not use. Now we had to bring in protocols that we were not going to accept medications from the COVID and COVID suspect areas to be returned back to the pharmacy. And medication storage policy, single strip policy, all those had to be refined based on the situation that we were in. Medical equipment, daily check of all vital equipment. Equipment with transparent covers or lamination to minimize the contamination of surfaces. We've all become scientists, I must tell you. Every single day, it's some kind of an innovation that is taking place. Regular cleaning of equipment after use. MOU with other hospitals so that we have equipment available in case we run out of vital equipment. And too much of room for innovations. That's been the major positive outcome of this pandemic, I would say. Disinfectants and cleaning solutions, selection, procurement in bulk, making list of all the local vendors, contacting them, making sure that they are all stored adequately, and disinfectants regularly available across the hospital. In case of short supply, we even have protocols designed as to how we are going to prepare hand sanitizers or other alternate methods of cleaning. So those also we went into preparatory mode towards the pandemic. Additional responsibility for non-clinical staff, so that our housekeeping staff are relieved into the clinical area and they manage their own offices and they start cleaning their own tables and desks. Logistics, F&B, transport facility, dry, fresh ration, how we were going to procure them, keep them available for our staff, doctors, nurses, and also our patients, and contacting local vendors. So there were multiple teams that were created to work on all these aspects. And transport facility for the staff, the doctors, nurses, particularly in a lockdown when the transport is not available, issuing vehicle passes for them, communicating with the local administration, making sure that our healthcare workers were not harassed and sent to the respective places. Clinical management, yes, very strong clinical teams on a day-to-day basis look at literature available, go through them in detail, literature from all over the world, and started developing protocols for their own areas. However, this would be vetted by the core clinical team, and these protocols have been established. But it keeps changing, extremely dynamic protocols that are coming in every single day. Financial management, a challenge. Now we used to run in 100% capacity, or almost 80 to 100%. Now we had to close all essentials. Only emergencies we could run. So therefore, the financial crunch, we had to manage that. Appropriate use of resources is one thing that we had to really stress upon, so that we don't incur a loss. Financial planning and management has been a major challenge, reducing unnecessary expenses, how to cut down expenses when the cost of PPE and other requirements have actually gone up. So I hope this situation ends in the next 1 or 2 months, because I don't think beyond a certain point it's actually viable in a resource limited setting to manage our hospital with the available resources. Now, this is what I had to tell you about what most hospitals have put together. But the most interesting thing that has happened is low-cost solutions in a resource-limited setting like India. Everybody, whether it is the engineers, doctors, nurses, even the auto drivers have become innovators, reverse engineering all over the place, and to appropriately match the expectations and the need of the healthcare workers. I must really thank people who have been involved in doing this. This has worked out wonders. These small innovations, smart innovations, have actually helped us to really work around the system during this pandemic. Now look at these masks. These are, some of them are with OHP sheets, projection sheets. People start, at least for the people who are not in the COVID areas, these are extremely useful. Now look at these, the train bogie converted into a COVID bed. Now, this is a picture from the Zydus Hospital in Ahmedabad, where they've actually converted container into COVID room. And these are rooms that are kept outside the hospital also, and making sure that these patients are managed appropriately by the clinical teams. Look at this. This is a fire mini tender that is used for actually now disinfecting the hospital premise. Now this is a UVGI for basically decontaminating N95 masks. Now in all this, we have seen excellent teamwork. I think the country has come together. All healthcare professionals have come together, particularly supporting our doctors, nurses, and other frontline healthcare workers who are standing there and supporting this country to stand up today. And I really, really thank all of them. Thank you so much for everything you do, my dear doctors, nurses, and all the healthcare professionals facing this pandemic and before it. You have taken care of families at every step, from birth to death. You are now walking right into the fire to help humanity get through these tough times. And my dear friends, this presentation is dedicated to your strength, resilience, and care. Continue to do the good work, and I'm sure all of us are with you. Thank you very much, ISQua, for this wonderful opportunity given to me.
Hi, Lallu. Thank you so much for a fantastic presentation. I'm sure you can't see the chat box as you were presenting there, but there was just nothing but overwhelmingly positive and fantastic comments coming in. It's an amazing, just what you finished up on there as well. It's extremely inspiring and heartening, I suppose, to see so many people who want to improve the safety of healthcare coming on together. And I think this presentation as well was a fantastic demonstration of the strength of the partnership between CAHO and ISQua, and how just the healthcare community in general can join together for the greater good and and work towards the same goal, which is obviously improving the safety of healthcare. At this moment, I'm going to invite everyone in our audience to begin to ask questions through the Q&A box. There are going to be a lot of questions that we probably won't be able to get through them all. So if there are questions there you'd like to see answered or prioritized, you can upvote them by using the thumbs up, and we will start at the top of that list. So if there are questions you would like to see, please vote for them. And just a bit of housekeeping as well. If you enjoyed today's presentation and found it helpful, then please feel free to check out our COVID resources page as well. We've collated different resources from all around the world relating to different backgrounds and contexts, so there's something useful for everyone there. And we also have another upcoming webinar on Thursday at the same time as this one started on Thursday, which is an expert discussion panel with Professor Trish Greenhall, Philip Crowley and Jennifer Martin on preventative measures for COVID-19. And again, just to reiterate the strength of the community that we talked about, it's been really inspiring to see everyone come together and help and provide resources and support. And if you like what we're doing at the moment and want to continue to support us in doing so, then please consider becoming an ISQua member if you're not already one. On that note, I'm just going to pass over to my colleague Katrina, who is going to very quickly run through the ISQua Southeast Asian Community of Practice, which I think will be of interest and a benefit to a lot of people in the audience here today. So we'll do this quickly and then we'll jump straight into the Q&A.
Thanks, Brian, and thank you very much, Dr. Lallu. That was absolutely fantastic. It's great to see so many people coming together, working together. For the first time, I think, ever, you know, the whole world is united against the same kind of foe, same enemy. So it was fantastic to see what you're doing. So I just wanted to very quickly say hello to you all and to share with you a little bit of information about ISQua. So as you probably know, we're a global organisation and we have members in over 90 countries, and we're very proud to be a partner with CAHO. So along with one of our board members, BK Rana, I help to run the Southeast Asia Community of Practice, and this is a community that's really just specifically for people in that region. So it's open to anybody who's interested in sharing and learning from counterparts in the region. And as we all know, Southeast Asia is a very impressively diverse place, diverse in culture, in history, religion, and I suppose that makes it a unique place to learn from and to see the opportunities and challenges for healthcare quality improvement there. So this community of practice, we have meetings on Zoom just like this every 2 or 3 months. But obviously, you know, if there's more members, we'll have more frequent meetings, I think, because people might want to share their own experiences. So so far we've had Dr. Vikram Datta, who has spoken on the nationwide quality of care network. We've had the experiences of Dr. Sonia Trika, and that was on how she was involved in initiating quality culture in public hospitals in Haryana state, I believe. And we've also heard most recently from Dr. J.L. Meena on the role of NAHAB PMJAY in universal health coverage. So that was really, really interesting to hear from them. And we also arrange a networking session, which is excellent, really, for meeting your counterparts, and that happens at the ISQua International Conference every year. So anyway, if you're not already an ISQua member, I just wanted to show you here. So I just have to share my screen. There we go. You can see that there. So yeah, so we have membership and fellowship, but we have discounts for low income countries, for lower middle income countries, and also for every income level. So if, for example, you're from India, Bangladesh, Pakistan, Myanmar, or Vietnam, it's half price for membership. So that would be €75, which I think is about 6,200 rupees. I did Google that. And also you can do the fellowship. So that's the fellowship and the membership bundle is also half price, and that's I think it works out at around 18,000 rupees, a little bit more than that. And then if you're from Malaysia or Sri Lanka, there's 25% off membership. So if you're already a member and you're not in the community of practice, I have this really very brief video just to show you how to join, because once you log into the back area of the website, it can be hard to find your way around sometimes. So just a very quick video here for you. So you're logging in, and when you get into the back end, you go up to the top right hand corner, click on edit profile, and then that's not a very nice picture of me. Down to the bottom, become a COP member, and then you'll find the Southeast Asia Community of Practice in there, and click join. So that's it. So if anybody has any questions, I'm very happy to take any questions you have. I think most of you have my email address, or if not, you'll have the fellowship email address. So thank you very much, and I'm delighted to be here with you and to listen to Dr. Lallu's presentation. So I'll hand back over to you now, Brian, and we can go through the questions. Thank you.
Brilliant. Thanks a million, Katrina. And again, thank you so much, Dr. Lallu. So yeah, we'll go straight into the Q&A here. Our first question is from Akio, who thanked you for a wonderful presentation. And he's asked, is there any study or data that accredited hospitals are dealing well compared to non-accredited hospitals? It might be difficult to develop accreditation standards for a crisis, especially when we're in unprecedented times like a pandemic. Is there any scope to evaluate resilience or things like that in accreditation standards?
I think it's a very wonderful question. We need to really look at it very critically. At the moment, everybody is in the phase of preparing and getting ready and admitting patients. So we have initiated a study now to try and understand how things are. Actually, we've developed a template, and this has now gone to the ministry for approval. So we should be in a position to understand that. But I think we are not yet there. It may take probably another few months to understand whether there has been any impact at all, accreditation versus non-accredited hospitals. But to tell you, most of these patients are managed by public health facilities now. And most of the public health facilities are not accredited, except some which are accredited to the government standards. So let's see how best we get the data and try and compare and see what's exactly happening. Is accreditation really having an impact? Let's see.
Excellent. Thank you, Lallu. Our next question is from Neeraj. Should there be policy of testing all admissions to rule out COVID infection?
I think we are reaching there, but our testing capability has been very limited. Now, slowly it has increased and we have reached 1 lakh per day. So with time, I'm sure this is going to come. And we are almost going to be living with it for the next 1.5 to 2 years. So a situation is going to come when all pre-op, all admissions probably are going to get tested. And I think we are already reaching there.
Brilliant, thank you. Our next question has asked, lots of guidelines are released, but are they really implemented? Is there any monitoring body to check or monitor the progress? Also in India, not all hospitals are corporate or big. Small nursing homes also work in rural areas. So what about such hospitals, and what hospital preparedness can be suggested for those?
Yeah, so as the word rightly says, these are guidelines. So these are not prescriptive. So you take good practices from the guidelines and try and implement them. Now, if you look at it, everybody is concerned. Everyone is concerned about their safety and also the patient safety. So even smaller hospitals have put down very robust mechanism for adopting to these guidelines. They have customized to their requirements, their resource limitations. But however, some way or the other, they have adopted guidelines. So IMA has actually looked at all these guidelines and prepared very simplified formats for hospitals to follow. So I think, in a way, I would say all hospitals are prepared. May not be to the extent of admitting patients, but at least to the extent of taking care of their facility, their own healthcare workers and their patients. Yes.
Excellent, thank you, Lallu. Our next question is from Prabhavathi. Could you please brief us about post-lockdown measures?
Yeah, so that's going to be extremely challenging because now our cases are going to go up, number one. Now, once our cases go up and let's say we reach a stage where they are going to come down, and thereafter, how are we going to really create a situation that our patients are actually safe? So you need to now start thinking about zoning of your hospitals, green, orange, red. Now the green zone is completely COVID-free. The orange could be those areas where you are receiving the patients. And the red is the area where you are keeping your suspects and your positives, particularly in larger hospitals. So I think many large hospitals are now moving towards that, because not that this pandemic is going to hit every state, every district or every town in this country. So, I mean, if you are in that situation, yes, places like Chennai, Ahmedabad, Delhi, Calcutta and Mumbai are struggling. But there are many small cities which actually do not have many cases. But we need to get prepared for the post-lockdown. And of course, after that, how are we going to actually function? Make sure our hospitals start functioning. Yes.
Excellent. Thank you, Lallu. Our next question is from Ravindran, who said, great presentation. From your experience so far, what has been the weakest link in the chain of hospital preparedness, and what are your suggestions to overcome it?
So I think the weakest link has been, of course, putting down appropriate protocols in consensus with everybody, number one. Second thing is to make sure that everybody is trained to the protocols. Training has been a major challenge because now with this with the social distancing norms, our traditional way of training, where you have a classroom training or have everybody in an auditorium and train them, has almost become null and void. So we are all, really struggling to get people trained on actual protocols and with the mask and everything around and the fear of contracting infections. So that's been a major challenge of communicating appropriate protocols and making sure that every healthcare worker is trained. So technology, yes, it's coming to our help, particularly by way of Microsoft Teams or Zoom and other platforms. It is helping us, but it's nothing like a face-to-face training. Whatever you do, you really don't know whether they've understood. So that's the major challenge and the weak link, I feel. Thanks, Jagaswati sir, for that question.
Excellent. Thank you, Lallu. Our next question is relating to mental health during the pandemic, and how do we cope with it? Yeah,
I don't think we have really gone to that stage of mental health, to be very honest. Yes, there are very many challenges of depression and people really finding it difficult to cope with the situation. But most hospitals have got kind of counselors to talk to them, making sure that such people are not put in the front. People with problems at home, handling small children without any creche facility, without schools being closed. So I think by and large, we have been very considerate to our staff. But when the situation goes out of control, yes, there are very many challenges. So we need to really look at this strategy probably in the next few weeks. It's going to be tough. It's extremely going to be tough, I would say, both on healthcare professionals and also people who are locked up at home now. We are now seeing increasing numbers of suicides that are coming up in the community. So it is going to be a major challenge. Without alcohol in the community, people really, I would say it's a challenge. We are going to face it very badly in the coming days.
Excellent. Thank you, Lallu. Our next question from B-Man. Which organization in India controls and checks the quality of N95 and masks?
Yeah. See, there are many organizations available, particularly the mask, the surgical mask, the medical mask. There's an organization called CITRA, and most of the, production, or rather the manufacturers get the CITRA certification. Otherwise, it is all FDA approvals and different country approvals, different standardization bodies in the countries. For example, the N95 and your FFP1, FFP2, all those depending on the country certification. However, for the medical mask, CITRA is a body. CITRA is the South India Textile Research Association, which is based out of Coimbatore. So most of these medical masks and the other masks are certified by CITRA based on specifications for medical use.
Excellent, thank you. Our next question is from God's Will. How can you effectively triage patients when many patients are visiting the hospital at the same time and through multiple service points?
Yeah, so the first thing to stop would be the multiple service points. You need to have one point entry for the patients. For emergency, yes, your ED department, but for the other patients, you need to have your access restricted. You may tell me, yes, I have a OPD, I have one OPD in this block, one OPD in the other block, but you need to route them all through a common route. Otherwise, you are going to miss out. So it is best that you pass them all through a common point, get them checked, get the temperature screening done, have a pro forma filled out, ask them some relevant, pertinent questions. And those staff who are all the administrative staff, your secretaries and others can be trained to doing this. Your security staff can be used for screening these patients who are coming in. So you need to really look at the flow of your patients. Identify those areas through which your patients, see, you cannot function as normal. That's the first statement I made. You cannot function the same way that you were functioning earlier. You need to reroute your functioning to fit in the kind of patients that are going to be coming in, so that you don't miss out on these patients. Because what happens, sometimes you have these patients going and then suddenly they develop symptoms, and then the whole thing of contact tracing comes into picture. And smaller hospitals, contact tracing, almost everybody is then with some way or the other exposed to the patient. It becomes very difficult. So it is best to have them at the entry and make sure it is one point entry for everybody to go through the facility. Thank you.
Excellent, excellent. Thank you, Lallu. I'm conscious of the time now. I realize we've just gone past the end point. However, we might ask one more question if that's okay.
Go ahead. Thanks a lot. Go ahead.
Brilliant. Is the reuse of N95 advisable? And how do we know if the quality is still the same after 5 reuses? Is there a way to check?
Yeah, it's a burning question. But that is how enough literature is available to say that you could reuse these masks. So actually, there are various techniques also now available, whether it is UVC or your plasma sterilization. So best method is actually sun dry. You just have to use the mask, keep it aside for about 48 hours in a breathable packet, in a cover, probably in a paper pack. And there's enough literature available to substantiate this. This virus is not a very bad virus in the sense it is an enveloped virus. And the kill time is not very difficult. So therefore, you place it in a paper cover, allow it to dry for about 48 hours, then it is good. But let me tell you one thing, this is not for all COVID positive areas. Now, most hospitals have about, let's say, 5 or 10 patients who are admitted as COVID patients or more. Now, those masks, you have to avoid reusing them or put them through some kind of plasma sterilization or some other technology that is available. However, the majority of the use is from other areas where the patient, where your healthcare workers are, you're just protecting them. So those masks can very well be reused, and there's enough literature available. I can share some if you really want. And our dear friend, Dr. Anuradha Pichumani, has developed now a UVC in her hospital, and she's using it very effectively. It's just amazing technology that she has developed, and she almost uses it for 20 times. We have actually sent the mask now for CITRA certification to test the filtration levels out. So let's hope that that gets certified and we are able to provide that to all the smaller hospitals in India without any margin at all. It's a CSR from CAHO. We will do that soon.